I think that testing for molecular markers has really become a key part of taking care of lung cancer patients. A lot of what one tests for, I think, has to do with where they practice and what's available. At Mass General, where I practice, we have been doing a multiplexed panel called Snapshot on all of our newly diagnosed non-small cell lung cancer patients since 2009. So I'm lucky to have access to that testing. I do recommend all my patients get tested for a series of mutations through that panel, including EGFR and BRAF, KRAS, PIK3CA. There's some FISH testing that goes along with it as well, like screening for ALK and ROS, sometimes MET, FISH, HER2, and most recently RET. So I think there are a lot of tests that are coming into play. In the community, I think the most crucial tests to get for lung cancer patients are EGFR mutations, ALK translocations, and increasingly ROS, although that's a very small percentage of patients. So I think figuring out which patients to send molecular tests on is something that's in evolution. When all we had to test for was EGFR mutations, I think people were very focused on looking at clinical correlates and knowing that there was this association between smoking and perhaps gender, adenocarcinoma for sure, and race, that we could pre-select patients to test for. And that was important because the testing might be expensive, it was logistically difficult to get material. But now that we're looking for so many different driver mutations, and some of them are more common in adeno, and some of them, like FGFR amplification and PIK3CA mutations, we're learning are more common in squamous, and some are associated with low smoking, and some are associated with high smoking. It's become really impossibly complex to figure out, I think, which test to order for a patient based on clinical characteristics. And I think that the easiest way to try and capture as much of the patients that have driver mutations as possible is to kind of do a one-size-fits-all test with a multiplex panel and offer it to every patient, at least every patient with non-small cell lung cancer. I think we have to work with our colleagues who obtain these biopsies, so pulmonologists, interventional radiologists, thoracic surgeons, to really try and get more tissue the first time around so that we're not faced with having to approach people about getting a second biopsy to do this kind of diagnosis. We also have to work with our colleagues in pathology to make sure that as they look at the diagnostic tissue, they don't deplete it by doing 10 different IHC panels, which might not be necessary. As long as everyone's on the same page about conserving tissue and maximizing tissue, even then, there still will be patients who won't have enough tissue. And in my personal practice, I do often recommend getting a second biopsy very close to the time of diagnosis in order to get genetic testing. It depends on the patient. A lot of these targeted therapies are only available on a clinical trial. So if they're not going to be a clinical trial candidate for other reasons, maybe it doesn't make sense for that patient. But the majority of patients, even with squamous cell, even smokers, I will try to see if we can get a repeat biopsy if it seems feasible. I do strongly recommend that patients who have had a good response to a targeted therapy, be it an EGFR therapy, ALK, ROS, really any targeted therapy, if you had a good response, but then develop resistance, it's really important to try and get a biopsy. One of the reasons is to move the field forward. Even a small number of patients can help us learn so much and develop the next generation of therapies. But I think that it's very realistic now to explain to patients that there could be direct benefit to them from this biopsy. There may not be. We don't learn something that changes our plans or our treatment for every patient, but sometimes we do. Sometimes we see small cell lung cancer, which may change the chemotherapy options. Increasingly more of the clinical trials for acquired resistance are looking for patients with a specific mechanism, such as T790M, so it may make them eligible for a trial. So I recommend it to everybody, and I think that it has multiple levels of use.